Welcome, everyone. My name is Ted O'Connell. I'm one of the authors of Crush Step 1, the ultimate USMLE Step 1 review. This is the second edition of the book, and we're going through it chapter by chapter. This is part 8 of the Neurology chapter. We're going to start by talking about ear pathology and then move on to eye pathology. Beginning with ear pathology, vertigo, an illusion of movement despite being in a stationary position, or a sensation that the room is spinning. When evaluating a patient with vertigo, it is crucial to categorize vertigo as peripheral or central. Peripheral causes affect the vestibular system in the inner ear. Central causes affect the central nervous system. Central causes include migraine headaches, lateral medullary syndrome, vertebrobasilar TIA, cerebellar infarction, and multiple sclerosis. Peripheral causes are discussed here, beginning with benign paroxysmal positional vertigo, or Bppv. This is the most common cause of vertigo. It presents as short, intermittent episodes of dizziness provoked by head movements and associated with nausea and nystagmus. Bppv is caused by calcium crystals, or otoliths, that affect the cupula or cause abnormal endolymph movement. Otoliths are typically found in the utricle, but over time they may migrate into one of the semicircular canals. The posterior is most common. Bppv is diagnosed clinically, but can be confirmed by the Dix-Hallpike and Roll tests, which test the posterior and horizontal semicircular canals respectively. Treatment aims to reposition the otoliths out of the semicircular canals through the Epley maneuver. Anti-vertigo medications that include antihistamines such as meclizine and anticholinergics such as scopolamine can be given for symptomatic management. Munir Disease. Typically, this presents as vertigo, tinnitus, hearing loss, and fullness or pressure in one or both ears, but not all patients experience the same symptoms. It is believed to be caused by excess endolymph buildup in the inner ear, which over time causes dilation and blockage to cochlear structures. Herpes virus has also been linked to this disease, and acyclovir can be used as a possible treatment. It is a diagnosis of exclusion. Physical examination, brain MRI, and audiometry should be done to rule out other entities such as schwannoma. Treatment aims to reduce further fluid buildup. A low-salt diet and diuretics such as acetazolamide, as well as symptomatic control of nausea and vomiting. Surgery is a last resort. Destructive, such as vestibular neurectomy, and non-destructive, such as a shunt procedure, can be done. Vestibular neuritis. This generally presents after or during a viral syndrome, with a sudden onset of vertigo associated with nystagmus, vomiting, and gait instability. Unlike labyrinthitis, there are no hearing symptoms. Because of the clinical overlapping picture, it is crucial to differentiate it from acute vascular events, particularly cerebellar strokes. Treatment consists of a short corticosteroid taper. Infection. Acute otitis externa. A common cause of an earache or otalgia. This is an inflammation of the outer ear, the pinna, an external auditory canal caused by pathogens such as Pseudomonas aeruginosa and Staphylococcus aureus. Typically, it is known as swimmer's ear, occurring after swimming, in which the remaining water serves as a moist environment for bacterial growth. It can also be caused by trauma, such as ear scratching or cotton swabs, by occlusive ear devices, such as earphones or hearing aids, and by dermatologic conditions, such as psoriasis. In addition to otalgia, swelling can cause conductive hearing loss and, in severe cases, canal obstruction. Treatment consists of thoroughly cleaning the ear canal, removing cerumen, and treating inflammation and infection with topical antibiotics and steroids. Of note, when dealing with older diabetic individuals or immunocompromised patients, consider malignant, necrotizing external otitis, which can spread to the skull base and requires emergent ear, nose, and throat specialty evaluation. Acute otitis media, or AOM, also a common cause of otalgia. This is an inflammation of the middle ear, usually caused by pathogens such as Streptococcus pneumoniae, Haemophilus influenza, and Moraxella catarrhalis. The most important factor in the pathogenesis of AOM is eustachian tube dysfunction, which occurs secondary to allergic rhinitis or upper respiratory tract infections. Treatment strategy is controversial, but generally consists of watchful waiting or antibiotics, depending on the patient's age and overall clinical picture. Cholesteatoma, a cyst that is an abnormal accumulation of keratinizing squamous epithelium, which, if not surgically excised, expands over time, causing recurrent ear infections, mucopurulent drainage, hearing loss, vertigo, facial nerve palsy, and potentially life-threatening complications such as meningitis or brain abscess. Ramsay Hunt syndrome. This is caused by reactivation of herpes zoster virus, shingles, in the geniculate ganglion, which affects cranial nerve 7. As a result, facial muscle movement, sensation of part of the ear and ear canal, and taste function of the anterior two-thirds of the tongue can be affected. Typically, a patient presents with the 7th nerve palsy, or Bell's palsy, but on inspection of the tympanic membrane, tongue, and/or hard palate, eruptive erythematous vesicles are seen. Hearing impairment. This can be a concerning symptom for many, but careful examination with Weber and René tests should be done to differentiate between conductive hearing loss, which is often reversible, from sensorineural hearing loss, which is not. Conductive hearing loss is caused by a problem with sound wave conduction, which can occur in the external ear. For example, cerumen, otitis externa, or tympanic membrane perforation, or can occur in the middle ear, for example, AOM or otosclerosis. In conductive hearing loss, the Weber test, in which the tuning fork is touched to the middle of the forehead, localizes to the affected ear. The René test, which tests air conduction versus bone conduction, is abnormal. That is, bone conduction is greater than air conduction. Remember that in normal hearing, air conduction is greater than bone conduction. On the other hand, sensorineural hearing loss results from dysfunction of the inner ear, cochlea, or vestibulocochlear nerve. The Weber test localizes to the normal ear, whereas the René test is normal. Eye pathology. External, beginning with hordeolum. Also known as a stye, this acute, painful, external red bump on the eye is an infection of the sebaceous gland of Zeiss at the base of the eyelashes, or an infection of the apocrine sweat glands of mole. It can also occur internally, infecting the meibomian or sebaceous gland lining the inside of the eyelids. Treatment generally consists of a combination of warm compresses, incision and drainage, oral antibiotics, and pain control. Chalazion, painless internal nodule caused by chronic inflammation of a blocked meibomian gland. Initially, topical antibiotics can be used in the acute phase, but chalazions generally go away with time. Further treatment options include corticosteroid injections and surgery. Coloboma, present from birth, this defect in the eye is caused by the failure of the choroid fissure to close, resulting in a hole in one of the eye structures, the retina, optic disc, choroid, and iris. Extraocular movement abnormalities, extraocular muscle abnormalities. This is reviewed in figure 13-43. And remember the mnemonic LR6SO4R3, which we've discussed previously. Cranial nerve 3 damage. The eye looks down and out because of unopposed superior oblique and lateral rectus. Ptosis caused by the levator palpebrae superioris muscle disruption. Mydriasis and loss of accommodation because of parasympathetic disruption. Cranial nerve 4. Downward gaze is defective, so the head is tilted toward the side of the lesion. Cranial nerve 6. The eye looks medially because of unopposed medial rectus. Cataracts. Crystalline clouding of the lens or lens capsule that results in opacification and obstruction of light. The two most common causes include senile cataracts because of old age or congenital cataracts. However, some can be acquired, for example, from diabetes, trauma, infection, or prolonged steroid use. Pupils, beginning with Marcus Gunn. Often seen in optic neuritis, this afferent pupillary defect is seen during the swinging flashlight test, in which shining light in the affected eye produces less pupillary constriction relative to the unaffected eye. Argyll-Robertson. This highly specific sign of neurosyphilis, known as prostitute's pupil, presents as pupils that constrict to accommodation when the eyes move from looking at a distal object to a near object, but they do not react to light. Glaucoma. An eye disease characterized by damage to the optic nerve because of increased pressure in the eye, intraocular pressure. It is typically divided into two main categories based on the angle between the iris and cornea. The vision loss typically begins in the periphery. This is in contrast to macular degeneration, in which vision loss is central. Open-angle glaucoma, which represents 90% of cases of glaucoma. This is insidious onset of painless vision loss associated with increased age, which is not noticed until the disease has significantly progressed. The only signs of this disease include visual field loss and optic nerve changes, and increased cup-to-disc ratio. Secondary causes result from obstruction of the trabecular network from red blood cells, for example, vitreous hemorrhage, from white blood cells, for example, uveitis, or retinal elements, for example, retinal detachment. Closed-angle glaucoma, which represents 10% of cases of glaucoma. A sudden onset of pain, a mid-sized, non-reactive pupil, and injected conjunctiva, red eye, which requires emergency treatment to lower the high intraocular pressure. Usually the intraocular pressure is over 30 millimeters of mercury in these cases. This is classically precipitated by pupillary dilation, for example, being in a dark room. Further discussion regarding medical treatment to lower intraocular pressure will be discussed in the pharmacology section. If medical management fails, surgical methods such as iridotomy or iridectomy, canaloplasty, and trabeculectomy or trabeculoplasty are available. Posterior eye pathology, beginning with retinal detachment. An ocular emergency characterized by peeling of the retina and described as a veil or curtain being drawn over the visual field, which is preceded by flashes of light, eye heaviness, and floaters. Diagnosis is usually made by fundoscopy or ultrasound, and treatment generally consists of sealing retinal breaks via surgery. Papilledema. Asymptomatic optic disc swelling caused by increased intracranial pressure, which warrants further workup to discover and treat the underlying cause. Otherwise, vision loss can result. On fundoscopic exam, typical findings include venous engorgement, the earliest sign, loss of venous pulsations, blurring of optic margins, and elevation of the optic disc. Optic neuritis. Demyelinating inflammation of the optic nerve, usually associated with multiple sclerosis. This is often the first manifestation of this disease, which can lead to complete or partial painful vision loss. On fundoscopic exam, the optic disc is usually pale but can be normal. Treatment generally consists of steroids. Central retinal artery occlusion. Acute onset of unilateral, painless vision loss caused by occlusion, embolic, thrombotic, inflammatory, or traumatic, of the central retinal artery that can be irreversible if not corrected within 90 minutes. On exam, there can be APD. Hollenhorst plaque, or cholesterol embolus, pale optic nerve, and a red cherry spot. The ischemia causes whitening of the retina. However, the macula receives its vascular supply from a different source. Note that this can also be seen in carbon monoxide poisoning. Treatment generally includes eye massage, eye paracentesis, which lowers intraocular pressure to allow the embolus to move, oxygen therapy, and consideration of thrombolytics. Central retinal vein occlusion. Acute onset of unilateral painless vision loss caused by occlusion of the central retinal vein, leading to macular edema, ischemia, and neovascular glaucoma. Typically, on fundoscopic exam, there's extensive hemorrhage, giving a so-called blood and thunder appearance. Treatment generally includes intravitreal administration of steroids. Retinitis, inflammation of the retina that results in retinal edema and necrosis, often leading to scarring and visual change or visual loss. Normally, it is a result of infectious etiologies, including viral, such as CMV, HSV, or varicella zoster, as well as bacterial and parasitic causes, especially in immunosuppressed individuals. Retinitis pigmentosa, an inherited progressive degeneration of retinal rod photoreceptors leading to progressive vision impairment, starting from peripheral vision and dim light compromise to eventual night blindness, nyctalopia. On fundoscopic exam, bone spicules accumulate with time. Visual field defects. Depending on the lesion location in the visual pathway, a characteristic visual field loss is typically seen. Below are, as we will discuss, are common visual field anomalies and their corresponding lesions. You should look at figure 13-44 and try to get a good understanding of this figure. Unilateral macular degeneration goes with central scotoma. Optic nerve lesion with right anopsia. Optic chiasm lesion with bitemporal hemianopsia. Optic tract lesion with left homonymous hemianopsia. A Miles loop lesion, which is located in the temporal lobe, results in left upper quadrantic anopsia. A dorsal optic radiation lesion located in the parietal lobe results in left lower quadrantic anopsia. And a posterior cerebral lesion results in left hemianopsia with macular sparing. Internuclear ophthalmoplegia, also known as MLF syndrome. Internuclear ophthalmoplegia is a disorder in which there's a lesion to the medial longitudinal fasciculus, the MLF, which essentially connects the abducens nucleus, cranial nerve 6, to the contralateral oculomotor nucleus, cranial nerve 3, in the brainstem. As a result, there is medial rectus nerve palsy, with nystagmus and horizontal diplopia in the abducting eye on attempted lateral gaze, but convergence remains normal. In young patients with bilateral internuclear ophthalmoplegia, multiple sclerosis is often the cause. In older patients with unilateral internuclear ophthalmoplegia, stroke is usually the cause. That's the end of this section. In the next, we're going to be starting with pharmacology.